Hello everyone, welcome to Twilight Problem is Possibility, and this is Dr. Rajlakshmi, and today I am here to talk about discuss about leptospirosis, which is our tropical disease part 3. This is basically a zoonotic disease, means transmitted from the animals, infected animals, to humans. Occupationally transmitted disease, and whenever human comes in contact with contaminated urine or reproductive fluids of chronically infected animals. Those animals can be domestic or wild animals, cattle, dogs, pigs, rodents, cattle and wolves, all other wild animals. And a few temperature changes and few environmental conditions favors the growth of organism like warm, humid areas, tropical areas, seasonal rains. During rainy seasons, the frequency of the disease will be increased. Heavy rains and floods have been associated with outbreak of the disease. It's basically tightly coiled aerobic gram-negative flagellated spirochete, and it has been classified into 20 species. Among these 20 species, few are pathogenic, few are non-pathogenic. There are many species which can cause disease in humans. Among them, leptospirohemorrhagiae is a causative agent of Weil's disease, and other species can cause infection in the humans. These organisms once enters into the body of the humans through the can enter into the human body through the skin or mucous membrane if there are any ablations breach in the skin barrier. Once it enters into the human circulation, it will enter into all organs, all systems of the body. Initially, primarily it will affect kidney, followed by the liver, and it can affect spleen, respiratory tract, CNS, eyes, and genital tract. And the organism can stay in all these systems and can reproduce and grow and can cause severe disease. Wherever is the organism, it will penetrate the microcapillaries and can cause endothelial damage, capillary leak, and vasculitis. Especially in the kidney, it will enter into the interstitial tissue, and renal tubules can cause interstitial nephritis or acute tubular necrosis, oliguric or non-oliguric acute kidney injury. What are the symptoms and signs? All these patients will develop fever, severe myalgia, body pains, low backache, and conjunctival suffusion will be there. Most of the times, patient can have conjunctival edema and redness. Jaundice, jaundice will be there. Most of the times, the jaundice will be direct hyperbilirubinemia and with transaminase elevation. Patient can have thrombocytopenia, which can cause bleeding tendency, hemorrhagic diathesis, and most of the patients will complain of severe headache, bitemporal frontal throbbing headache, and retroorbital pain with photophobia. And this disease is biphasic. First 1 week there will be severe symptoms will be there like fever, myalgia, conjunctival edema and redness will be there, and after a gap of 1 or 2 days, patient will present to you with severe disease with liver, kidney, sometimes CNS involvement. Coming to myalgia, there will be muscle tenderness, especially calves. Both the calves will be tender, and lower back severe lower back pain will be there. Most of the scenarios, rash will not be there. The presence of, if there is any rash on the body, you have to rule out other diseases which can cause rash like chikungunya, dengue, and other viral diseases before confirming leptospira as the cause of the rash. Sometimes the rash can happen in the pretibial area. Few patients can present to you with dry cough, GI symptoms like severe pain in the abdomen, diarrhea, and abdominal distension, ileus. Pancreatitis is one of the presentation case of the leptospirosis, and most of the leptospirosis cases have been associated with with rhabdomyolysis. Rhabdomyolysis is one of the cause of acute kidney injury, along with direct organism induced injury of the kidney. And as organism can enters through the wound on the limbs, it can be associated with skin and soft tissue infection. So if patient is having rash, before confirming leptospira as a cause of the rash, you have to rule out all other viral diseases or all other diseases which can cause rash. Coming to eye signs, uveitis will be there, jaundice and redness of the conjunctiva, edema of the conjunctiva will be there. Anterior uveitis to acute severe pan uveitis involving anterior, middle and posterior segment of the eye. But these eye signs or symptoms are self-limiting. Sometimes they can recur after a week or months of the disease. 80% of the patient had leptospiral DNA in the aqueous humor detected by the PCR, because this organism can enter all possible tissues and then it can live there and reproduce there. Other complications of the disease: bone marrow failure, pancytopenia, leukocytosis will be there, thrombocytopenia, hemolysis, hemolytic anemia will be there. Coagulopathy is one of the presentation of leptospirosis. Wales disease is nothing but severe involvement of liver, kidney, lungs and brain. Acute kidney injury is one of the main pathognomonic feature of the leptospirosis. This acute kidney injury can be non-oliguric or oliguric. Most of the times it will be non-oliguric and potassium loss and nephropathy. So characterized by the hypokalemia and impaired sodium reabsorption, potassium wasting. So we should have close monitoring with electrolyte balance, and you should be able to monitor potassium levels regularly and need to normalize the potassium level. ARDS, severe pulmonary hemorrhagic syndrome, and most of the patients can have CNS involvement, CNS symptoms and signs like hemiplegia, transverse myelitis, GBS, and some patients can present to you with aseptic meningitis and altered sensorium. In case of the aseptic meningitis, if you do CSF analysis, there will be lymphocytic predominance with the total cell count up to 500. Protein levels will be elevated more than 50, 50 to 100, and glucose will be normal. These are the CSF findings in case of the aseptic meningitis. So this leptospira can involve all the symptoms, all the systems of the body from head to toe. It can involve central nervous system, eye, lungs, liver and kidney, and reproductive system, skin and soft tissue infections. The risk factors for increased mortality: presence of ARDS, CNS involvement, repolarization abnormalities on the ECG, acute kidney injury, and leukocytosis. The disease, as I told you, it's a biphasic disease. Initial 5 to 7 days will be acute phase. It's because of the leptospiremia, because of the increased parasite or organism load in the blood. The after 7 days immune phase, the immune system of the body will take over the disease process and try to kill the parasite, try to kill the bug, and during immune phase antibodies will be produced. But most of the complications, organ injury, we will see during immune phase after first week of the disease. How to diagnose? The diagnosis test, we can divide them into organism based. We can detect the organism directly with the help of microscopy or with the help of PCR test, or immune based, serology based. We can detect the antibodies IgM and IgG. Among serological tests, the gold standard test is microscopic agglutination test. In this test, we mix patient serum with antigen suspension, prefixed or pre-prepared antigen suspension of specific serovar, or we will include all the serovars or locally prevalent serovars, locally transmitted serovars. And once we mix both antibodies of the patient serum and pre-prepared antigen mixture, we have to look for agglutination under dark microscopy. The endpoint for dilution is the highest dilution of serum for 50% of the agglutination compared to the control. Paired serum samples at the interval of 4 to 5 days or 10 to 14 days or longer is required to confirm the diagnosis or to rule out the leptospirosis. So in the paired serum samples, the titer should be increased by fourfold. Fourfold rise of the titers in two subsequent samples at the variable intervals. That can be at the interval of 4 to 5 days or at the interval of 10 to 14 days, depending upon the presentation, depending upon the onset of the illness. If the titers will increase by fourfolds, we can confirm the diagnosis. But problem with microscopic agglutination test is we may not detect during acute phase. If patient presents early, we can miss the diagnosis. And in case of the past infections, the titers can be phenomenally higher. And this test mainly for epidemiological purpose. And another problem with this disease, this test is we have to maintain the antigens of all serovars in our lab. We have to maintain live cultures of all the serovars in our lab for antigen isolation. And the range of antigens used should include serovars representative of all the serogroups and locally common serovars. This is one of the provision we should have in our lab to go ahead with microscopic agglutination test. And there is a possibility of paradoxical reaction, means there is high possibility of cross reactivity. So the high titers can be we can see the highest titers even detected to a serogroup unrelated to the infecting one because of the cross reactivity. So followed by a relative serogroup specifically in the convalescent sample results for the detection of the microscopic agglutination test of both IgM and IgG antibodies. If there is suspicion of the cross reactivity with unrelated infected unrelated serovar, we have to repeat the test after a gap of 1 to 2 weeks for increase in the titers. So cross reactivity, paradoxical reaction is one of the problem with microscopic agglutination test. So all these drawbacks makes the test very much complex, and availability of the test is also bit cumbersome, bit less. So other test, isolation and identification of the organism. Blood cultures can be done. 1 or 2 drops of the blood, CSF or peritoneal dialysate can be inoculated into 5 to 10 ml of semi-solid or liquid medium at the bedside. Blood cultures with no growth can be used to inoculate leptospiral culture medium. So first we have to do blood cultures, and if there is no growth, we can inoculate that specimen into the leptospiral culture medium, and urine should be cultured from the beginning of the second week of the symptomatic illness, not in the first week. We have to culture the urine in the second week. Survival of leptospires in voided human urine is limited, so urine should be collected into a sterile phosphate buffered saline. Contamination of the urine cultures is a major problem, and use of selective media containing 5-fluorouracil or other antimicrobial agent is strongly recommended. Cultures are incubated at 28 to 30 degrees centigrade and examined weekly by dark field microscopy for up to 13 weeks before ruling out the disease. So urine cultures we can done by, but we should there is a preferred criteria to collect the urine. They have to collect in a sterile phosphate buffered saline, and we have to inoculate that urine in a media containing 5-fluorouracil or other antimicrobial agent to prevent the inhibition of other bugs. And the incubation should be done between 28 to 30 degrees centigrade. We have to do weekly dark field microscopy up to 13 weeks. Another serological test is ELISA IgM-FC. This test we have to do after a week of illness, after a week of onset of the symptoms. Second sample we have to repeat the second sample after 2 weeks. So increase in the titers in the second sample will confirm the diagnosis. IgM plus PCR, we can ELISA along with PCR is more reliable. Other tests are indirect hemoagglutination test and dipstick test in the serum to detect antibodies. Culture fluid media are used for primary culture. Greater yields and faster growth are obtained in the twin albumin media such as EMJH media. Then media with rapid serum. So if you want to do blood cultures, you should have this EMJH media with rifampicin, neomycin, actidione, or used for primary isolation from contaminated samples. The culture of these organisms takes almost 3 months, so it's impractical to come to a initial or immediate diagnosis. This test may not be is not useful in case of the acute scenario. We may miss the diagnosis and we may lose the patient sometimes. So if you have high suspicion of the leptospira, go ahead with your ELISA IgM or microscopic agglutination test if at all, if you have that provision. If IgM is positive, go ahead with your treatment. Even if IgM is negative, start with empirical antibiotic therapy and repeat the sample after a interval of 7 to 10 days. The organism has relatively long doubling time, 6 to 8 hours or more. They are highly infectious organism requiring biosafety level 2 facility. So if you want to culture this bug in your lab, you should meet the criteria of biosafety level 2 facilities. Unless you have this biosafety criteria, you cannot culture this organism in your lab. Mainly cultures are for epidemiological purpose. Serovar detection. Serovar detects leptospiral DNA in the specimen down to extremely small amount equivalent to the DNA content of about 10 leptospides or less. A limitation is the inability of most PCR assays to identify the infecting serovars. So if you want to go ahead with the PCR technique, the major advantage of PCR technique is you can identify the serovar. You can identify specific serovar and the sensitivity will be very high. You can detect you can detect as minimum as 10 leptospides or less. Even the organism load is very less, you can detect this disease with the help of your PCR. But the main limitation of PCR is sometimes it may not detect the infecting serovar. Dark field microscopy, it has the sensitivity specificity are very less because to detect bug under microscopy, you should have 104 leptospides per ml for one organism per field. So you have to see one organism per field. The parasite load, the organism load should be 104 leptospides per ml of the blood. So unless disease is very much severe, you may not able to see that organism under your microscopy. And if you want to check the urine microscopy, the urine excretion of the organism is intermittent. Sometimes you can pick up, sometimes you may not. So false negative results are very much high, sometimes false positive results also very much high with dark field microscopy. So among all tests, microscopic agglutination test is a gold standard. If at all, if you have provision to do this test, go ahead with microscopic agglutination test and repeat the test after a period of 1 week to 10 days. If there is four-fold rise in the titers, retrospectively you can confirm the diagnosis, but the availability of MAT is a little bit less, so we have to go ahead with ELISA IgM. If it is positive, well and good, you can continue with your treatment. Even if it is negative, clinically, if there is high suspicion of the leptospira, you have to go ahead with empirical treatment and you can repeat IgM titers after a gap of 1 week to 10 days. So increase in the titers, or if first sample is negative, second sample is positive, retrospectively you can confirm the diagnosis of leptospira. Clinically, if patient is febrile, myalgia, rhabdomyolysis, and AKI, liver involvement, direct hyperbilirubinemia is there. And on the history, if it is a biphasic disease, high likely it is leptospirosis. Go ahead with empirical treatment. What is the treatment? Coming to management part, I intravenous penicillin 1.5 million units IV every 6th hourly. Can be ampicillin 0.5 to 1 gram IV 6th hourly, ceftriaxone 1 gram BD, cefotaxime 1 gram 6th hourly, or doxycycline 100 mg PD, azithromycin 500 mg OD. These are all options available to treat the disease. You can choose any of this medicine as per patient's condition. you have to continue till almost for 10 days to 14 days of the therapy. If patient is pregnant, you can go ahead with azithromycin or amoxicillin or ampicillin, beta-lactams. Leptospirosis are susceptible to beta-lactams, macrolides, tetracyclines, fluoroquinolones, and streptomycin. Prophylaxis. Pre-exposure prophylaxis with doxycycline 200 mg once per week was effective to prevent the disease, especially in case of the military personnel who takes training in the forest areas. Doxycycline has also been studied for post-exposure prophylaxis by a couple of studies. Among those two studies, one of study has proven decreased incidence of the disease after exposure. So this is all about leptospirosis. So we'll meet up soon with another disease, the last part of the tropical disease, that is scroftitis. Until then, bye and stay tuned, stay safe.